I apologize, I cannot be with you. Anyhow, this is my short summary on how to choose the optimal treatment for our patients with mitral valve disease. These are my conflicts of interest. And I will tell you a story which is based on real events, but more importantly, a story which is ending with more confusion than you can imagine. I'm more confused than convinced about anything that I'm going to tell you. You know, there has been a revolution in the last few years with new interventions, new operators, new structures, and this has been inducing a new mindset, but also a lot of new evidence, which is creating some confusion in our mind for the plethora of different options we have. I can actually improvise and impress you with complex procedures like multiple clips in a single patient with Barlow's disease. I can show you some Batman procedures where actually we are able to electrify wires and to basically ablate the mitral valve in order to avoid LVOT obstruction in valve ring or valve in valve procedures. This is a case where we were able to do this in a valve ring procedure with a high risk of LVOT obstruction. And this is the end result of this procedure, which is one of the most complex procedures in our practice today, but is very efficient in reducing the risk of these procedures. But I want to make it a bit easier and go down with the technology center of such a review and start with the concept that today almost everything is possible. If you have the right tools and the right imaging, almost nothing is impossible. But is there a limit to what we can and what we should do? Well, I have a privilege to be able to perform procedures as a surgeon, as an interventionalist, and therefore I have a little bit different point of view than many of my colleagues. And I have also on one side a conflict within myself for each patient that I have to treat. And the conflict is because I'm not sure what is the best treatment for every patient. How do we choose between the different options? Well, there are several steps. And again, both procedures are fantastic. What is better for our patient? Well, I think I have three steps. All of them are very important. The first one is clinical, which means we choose procedures according to the evidence, according to risk benefit, according to the durability of our potential procedure and the effect over the lifetime of the index procedure that we are going to perform. Obviously, there is also a technical element because not all procedures are feasible. And in general, we try to choose the simpler one, the one more predictable, the one less invasive. But above all, in my daily practice and as a solution for the uncertainty, emotional factors are really leading my final decision, which I usually take together with the patient. You need to take the patient perspective. You need to become compassionate or emotional with your patients. In order to get the decision together with your patient, you need to be able to deliver an unbiased and totally transparent information, sharing also all your doubts, all the gray zone that we know. And after this process, you feel released if you have doubts in your mind. There are obviously advantages and disadvantages in many different conditions. Sorry, I go back one slide, where every procedure have advantages and disadvantages, and we need to find a good balance which works for each patient. Guidelines may be useful to help us in the decision making. However, guidelines are made for average decisions. The population we treat is not made of black or whites, it's a variety of colors. And the real world really needs a tailored approach for all our patients, which means that we need really to adapt to anatomy, the phenotype of the patient, but also to the lifestyle of patients and to their hopes, to their objectives in life. Degenerative MR is it's a condition that has a number of different options. You see them all here in this slide, but in principle, it is mainly a surgical disease. Complex anatomies in younger patients are best treated with a totally endoscopic approach, which is today standard practice in most of our hospitals. On the other hand, if you have at the other end of the spectrum, single lesions in elderly patients become, in my practice, a good indication for endovascular procedures. This is a very typical patient, is an operable patient, 80-year-old with a relatively low Euro score, but with a very good anatomy for a tear. Well, this patient will undergo, in my practice, almost in all cases will undergo, sorry, I have to go back, will undergo a tear procedure. However, the tear procedure in this particular patient, I want to have a surgical-like outcome where cure is achievable if there is a single leaf segment. What is a surgical-like outcome? No regurgitation, no stenosis, no residual motion abnormalities, just like you see here in this outcome you see on the right side here. Being able to perform transcatheter procedures bring me many patients who are asking for a transcatheter procedure. 57-year-old patient, active entrepreneur who doesn't want to miss one single day in his own practice, comes to me with a lesion which is absolutely impossible to be treated with a tear. It's a very large flail, resulting potentially in a stenotic procedure lesion. This patient, I was able to convince him that surgery would have been a much better choice, and he underwent an endoscopic procedure with chordal repair, and he was very happy at the end of it. There are also conditions where minimal invasive is not the best solution. We see many patients with severely calcified annuli. These patients, particularly in the younger age, they become surgical candidates again, where we can do a profound decalcification and the restoration of the regular anatomy in many of these cases. Usually we do these cases in sternotomy, although in some cases we've been able to do it also, like in this particular case, in an endoscopic fashion. But this obviously requires a lot of expertise and a lot of patience to be able to perform a decalcification in a young patient in an endoscopic approach. But let me go back to transcatheter procedures, which are actually bringing something that surgery don't have. In surgery, we observe very well the anatomy, but unfortunately, we don't see the function of the valve. We work with the valve which is not functioning. While valve function is always in front of us, we can do Doppler and see a real-time MR reduction for any procedure we perform. So in this case, I think this is really the reason why for functional MR, transcatheter procedures are very important. Functional MR was initially not the center stage for procedures. In the Everest trial, very few patients were treated by TEER with functional MR. The majority of TEER procedures in the Everest were done in degenerative ones. But once the procedure became available in Europe, the majority of patients treated in Europe in the beginning of our practice was functional MR. This is the results from the Access Europe, where 77% of patients were functional MR as compared to 23% of patients with DMR. The co-opt and mitral FR have been creating a bit of chaos in our community, showing different phenotypes and different levels of indication. We know what are the co-opt phenotype, which is a patient with not too much dilated ventricle and some preserved contractile function, no right ventricular dysfunction, no acute syndromes, and severe MR. This is a subset of patients with predicts for better outcomes, and so today most people believe that co-opt is the way to select patients. On the other hand, a trial which has been highly recruited in Greece showed with SHAPE-2 that even patients with less than severe MR may benefit from this procedure, both in terms of freedom from rehospitalization and improvement of quality of life. Still, the debate is open. There are many subphenotypes of functional MR, and so we need to be ready to be, again, able to optimize our therapeutic offer to the subcategory of patients we are treating. And we talk about phenotypes. There are many evolving indications for these procedures, particularly the acute indications are very important. We use this procedure in patients with SAM and hypertrophic cardiomyopathy. This is a case with, you can see a hypertrophic cardiomyopathy with mainly a problem of SAM with obstruction of the LVOT. We also use this in failed mitral valve regurgitation, mitral valve repair cases. It's a very useful and common indication in our practice. In patients where we are able to implant the clip, usually we have an excellent, good result at the end with double orifice end ring, which is a really surgical-like repair, aiming for long durability. We have been using now this procedure in congenital patients. I have a series of Fontan physiology patients, which are requiring multi-professionality around the table. I'm working with pediatric cardiologists to understand physiology and anatomy in very complex patients. And in these patients, we really can obtain good results and improvement of quality of life. An important application is the acute mitral regurgitation, both in patients with ruptured papillary muscle and in patients with acute ischemic MR without mechanical ruptures. This procedure may stabilize the patients with very minimal impact in the risk. Obviously, not all patients are candidates for repair. Replacement is going to be an alternative. There are many devices at the moment. Replacement obviously is very important. Again, what is the best option? We don't know. Again, anything is possible. How to choose in between all different modalities? Well, first of all, remember there are many options we have around the table, and adapt the option to our patients, not the opposite. The patient should not be adapted to what we can offer. There is a value in choosing surgery versus structural interventions in some patients where you can achieve best anatomical outcomes and full service. On the other hand, the structural intervention allows a culprit lesion approach with a stepwise approach, which sometimes will offer a lower risk profile as compared to surgery. There are different options, different targets of therapy. What is fundamental is that we work as a team. Valve centers and valve networks of care are very important. Understanding the issue of lifetime management in our patients, understanding what we do in the cath lab or in the operating room is only one step of the procedure, one step of the management, and a team approach is fundamental to obtain the maximum from these patients. Thank you very much for your attention.
Dr. Maisano, convincing as always, embodies the heart team. He could be a heart team on his own. It is very important to understand, if I'm allowed to offer a few comments, that as coronary artery disease, so too mitral valve disease, it's not black and white anymore. And with evolving technology, we now have a whole quiver in our armamentarium, many solutions, which, as Dr. Maisano, and I think that was the essence of his presentation, which we can choose from. Hence, this is also the way we approach it at the Yale Hospital, I guess at Onassis Heart Center, is we relay to the patient all the possible options so he can make the best choice with plus and minuses. It's not anymore just median stenotomy or a catheter solution. There are endoscopic, minimal invasive procedures that can be offered to reduce the trauma, eventually the burden to the patient. I think we are living in amazing times, very promising times in terms of personalizing, individualizing the solution. Where I think we should work together as Greeks in our country is to improve communication between ourselves and quality control, quality assurance, maybe perhaps set up a database so we can follow up on these patients after the treatment they received. Because I keep wondering why some countries can establish perfectly transparent heart teams and others don't. Germany, for example, usually there is a very good communication and cooperation between chief cardiologists and chief heart surgeons, and they tend to be role models of collaboration and functional heart teams. And I wish that we could establish it in Greece as well, according to the example and mantra that Dr. Maisano shared with us, and I think we're on a good path. Perhaps Dr. Pavlides can share some thoughts on that.
Yeah, I think that's very appropriate as an analysis, and I would add that what we need probably in Greece is our surgeons. I mean, my co-chair is excluded, of course, because he is already doing it, but I think that in most of the hospitals, our surgeons are not really familiar with the transcatheter techniques. And even when they are engaged into the heart team, they only think about surgery and they cannot really appreciate that there is a spectrum that, maybe a combined approach or one or the other can be. In our heart team at the University of Nebraska, for example, the champion in the M tier is our chief surgeon, Dr. Moulton. And he really wants to do that. I mean, he is almost, as a surgeon, able to do it by himself, a percutaneous technique. So we know that, between us and them, we can understand the different options, as Dr. Kofidis said, and this is really not black and white. And I think we're going to need more of this combined approach and shared experience. Like, we appreciate the surgical techniques, we probably more, but the surgeons do the same for the transcatheter technique. So we can really offer the best option for our patients in a field that is changing all the time. It's really just moving very fast. Dr. Iakovou.
I definitely agree with both of you. Of course, yes, and we learn a lot from surgeons as interventional cardiologists. And actually, most of the things that the interventional cardiologists do in the structural work is trying to replicate some of the procedures of the surgeons did. For instance, the MTR is like the Alfieri stitch with no ring. So yes, I suppose that this is the way to do. So in our center, the last few years, we are doing a weekly basis, a heart team. We try to implicate, most of the time successors, but not always, the surgeons. And of course, some of the surgeons are reluctant to do. Sometimes we will speak on different, let's say, levels. But at the end of the day, this is a progress. And the thing is that at some point, I think we will talk to each other, in the same level, and because the most important thing is to treat, in the best way possible the patient. This is no different.
And it's not only the meetings of the heart team. I would say that, what we have achieved, for example, in the University, again, of Nebraska, is that we have a specialized valvular clinic where we both see the same patient with a valvular disease. It's the cardiologist and the cardiac surgeon at the same session, so they get the same answers. Now, this might not be feasible in a private practice setting or anything, but it underlines the importance of the common and cooperating approach to the patient. I know that Dr. Lerakis is online, so before we introduce him for the next online lecture, I would like to get his comments actually on the topic that we are talking. Stamatis.
Yes.
Good to see you.
Καλημέρα από τη Νέα Υόρκη.